I'm Dr. Kimberly Bruneau. I'm an obstetrician gynecologist here on staff at Adventist Hinsdale Hospital, and I have been on staff since 1989. I received a call from Mike Gable asking me if I would be interested in participating in a business intelligence program that was beginning here at the hospital. My understanding was that I'd be presented with a variety of comparative data, particularly from operating room procedures that I did as a gynecologist, and those would be compared to my peers within the department and use that information to see how we could improve quality care, again, in a cost-effective manner. As a physician, I was curious about the data. I was curious about how I would fit in among my peers. I was curious whether I was costing the hospital more money than I needed to be, whether I could be providing more effective care for the patient. I had questions on many levels. I met with Keith Richardson and Mike Gable to review my individual data. The data was presented in a private setting and was completely blinded, meaning that I could see my individual data represented against other physicians in my department, but was not able to identify who the other physicians were. That took away some of the potentially threatening feelings that I might have otherwise had listening to or being presented with some of this data. In particular, when I was presented with data looking at the cost of care to provide Da Vinci robotic surgery, I was surprised and curious about why in some areas the cost of me providing that surgery for one of my patients was so much higher than many of my other colleagues. It would be helpful for me to know, are the nurses observing that Dr. B, when that doctor orders a postoperative analgesia plan for a patient after hysterectomy, how does that patient do in terms of early ambulation and earlier mobility to be discharged versus my particular plan that I routinely use? So I think we can utilize nursing to give us the feedback, give physicians feedback, to design power plans that are specific to particular procedures, such as a Da Vinci robotic hysterectomy. This would allow physicians to have information within the power plan to select that would more efficiently direct the nurses to post-operative care and assess and evaluate them for early ambulation and earlier discharge. I can recognize where some physicians might look at this data and feel quite threatened. I chose to look at the data and use this information to not only personally help me become a better physician, but also recognize that we are all a team together here, and some of the healthcare changes that are coming down the road will require us to be working together even more intensely.